It is 10:45 and our break is now over. I'd like to welcome everybody back, including my spectator enrollees. Before we begin our discussion, I'm going to give you a few more instructions. So, just one second. I'm sorry, just one second. There we go. Be sure we're all on the same page. You should have this open. Oops, here we go, one more time. And if you open the link that says Go to Discussion, both your MCQs, your answers, and your performance will appear. It'll look much like this with the case number and the question number and what your response was as opposed to the group response. The green answers are the correct answers. And before we begin our discussion, I have just a few more directions. Dr. Chopra is very thorough in his discussion, but if you do have a question, please be very specific. Use the question panel and include both your case number and your question number. These will be answered at the end of the discussion, and Dr. Chopra will try to answer as many as possible within this time. So if we are ready to begin, let me turn things over to Dr. Chopra. And Dr. Chopra, you should now have the screen.
Thank you very much, Ruth. And I welcome all of you to our March sessions of Series 1. Series 1, Face the Core. Please be patient. You will see all the responses. Everything will be shown to you. Everything is working excellently well. All of you have probably now gotten some idea of how to prepare for the core. One of the things that I would like to bring to your attention is, please do not miss out on anatomy and techniques. They are very important. They are on the exam. They will be asked, and they are a fair game. Having said that, particularly anatomy is what I call as yours for the taking. It is a very low-hanging fruit. All you need to do is know what is what. Sometimes the image quality may be such in the exam that you're not able to make out, but then use all the information that is available to identify the structure that something is arising from. What we do is we divide our each case. The questions on every case, you can ask questions from a number of different perspectives. So we divide them into anatomy, technique and physics, findings, diagnosis and differential diagnosis, and the management. So here we go. Let's activate the first case. And as I activate it, those of you who have not seen it, you will see it on your MCQ and now the discussion panel, where you'll see your results. So the first question on this case is, which of the following is the most likely diagnosis? All of you except one have gotten it correct. The diagnosis is emphysematous pyelonephritis. Why is it emphysematous pyelonephritis? Because there is air in the renal parenchyma, there is air in the subcapsular space, there is a lot of straining. So this is an easy question. You are able to answer this. This is just clear. It is an Ant Mini. But then the question number 2 arises, which of the following features predict a poor prognosis in this case? And often we find that people really do stumble on it, and this is where we have added, you see the extra crease in that you need to know a little more about emphysematous pyelonephritis to answer these kind of questions. So this is emphysematous pyelonephritis type 1. So what that means is that there is very little fluid. And why is there very little fluid? Because you cannot, the patient has not been able to mount a response against the infection. The patient is overwhelmed, their defenses are overwhelmed, and therefore they are unable to form any pus. If there is a lot of fluid, that means that the patient's defenses are fighting against the infection. There is a lot of, there may be a lot of there is a lot of pus, and therefore it has to be removed. Let me just answer this question. For the person who cannot get on the discussion panel, just go to, just log out of Face the Core, come back again, and you will get to the discussion panel. Now, the question arises, why cannot this be pyonephrosis? Because there is, and we will answer these questions in the end, because this is not an obstructed system. Pyonephrosis is infection in an obstructed system. And when the fluid is formed, that can be formed in any compartment, but you will see it whether it is in the renal parenchyma or in the perinephric region, but the patient is forming pus in and around the kidney. And in that case, it would be a good prognosis, because all you need to do is then drain that abscess, and the patient has a better prognosis. With this one, type 1, patient has a very poor prognosis because they are being overwhelmed. Going on to the next, which of the following is the predisposing factor? You all know that diabetes is the predisposal factors. All the others have been looked at. HIV, AIDS has been looked at. Clostridial skin carriage has been looked at and have been found not to be of any predisposing importance. Which of the following would be the definitive treatment in this patient? It would be nephrectomy. Percutaneous drainage would be appropriate if there was a lot of fluid. And trial of IV antibiotics is okay for pyelonephritis, not for emphysematous pyelonephritis, but in this case it is nephrectomy that needs to occur because this is type 1 emphysematous pyelonephritis. Going on to case 2, which of the following is the most likely diagnosis? This question did get a rating of 5, and basically what you're seeing is that is the urinary bladder here. There's a lot of contrast outside. The contrast is well defined, and there are these filling defects almost at the top of the contrast which have a sausage-shaped appearance. This is intraperitoneal bladder rupture. Those of you who call it something else do need to realize that this is the bladder here. The Foley's balloon is not misplaced. It is in the bladder, and this is the contrast outside the bladder. Intraperitoneal bladder rupture is very typical, and you need to be able to identify that. Which of the following is the safest way of instilling contrast in the urinary bladder during the examination shown? The exam shown here is a retrograde cystogram, and what you're seeing here is that the catheter has been placed in the bladder, and the only way, really the safe way of putting the contrast in is with gravity. And you all have done that. You all remember it. Those of you who got it wrong, please correct yourself. You do not inject with force into a urinary bladder because you can rupture it. You do not know what the condition of the wall of the urinary bladder is. So you always drip contrast with gravity. Then the next question is, which of the following structure forms the sharp lateral and inferior margins of the superior contrast collection. So basically there are two contrast collections, one within the bladder and one outside, and the question is, what is this? And the answer to that is that these are the margins of the peritoneal cavity. This contrast is within the peritoneum, and the margins of that are well defined, and that is one of the ways that you differentiate contrast inside the peritoneal cavity, which is well defined within a cavity, and contrast outside of the peritoneal cavity in the extraperitoneal tissues, which is all flame-shaped and very irregular. And we will show you that, I think, in one of the further images. Everything else is not correct. Which of the following is responsible for the filling defects at the superior margin of the superior contrast collection? These are sausage-shaped. They look typically as bowel loops should. They're elongated, and there's contrast between them. Again, it is something that you need to get very quickly, and don't lose marks on something as simple as this one. Then which of the following is the next best step at this point? Should we inject should we inject air through the catheter? I'm sure none of you have ever heard of a double contrast cystogram, not done at all to my knowledge. You don't need to do a suprapubic cystostomy just yet, because this patient is going to have to be treated with surgery, not with suprapubic cystostomy. You don't want to take the catheter out because they do need catheter drainage. What you do need, though, in all patients with a retrograde cystogram is to get a post-void image or post-drainage image. And the reason for that is that you do not know whether there is any other contrast lurking around behind the urinary bladder, which may be in the extraperitoneal position, and that would make it into a mixed type of bladder rupture. So the correct answer is post-drainage image, not any of the other ones. Okay, case 3. We will go to the questions at the end. Your questions that you're sending, let's go through these. In which of the following anatomic compartments is the abnormality located? It is in the retroperitoneum. You all know that, and the question is, which space of the retroperitoneum is it in? It is not in the psoas muscle, although it is touching it, but if you look at it, the epicenter is far away from the psoas muscle, so it's not arising from the psoas muscle. Is it in the anterior perirenal space? The anterior perirenal space lies ahead in front of the blood vessels where the pancreas lives. That is the anterior perirenal space. This mass is going behind the vessel, so it is not in the anterior perirenal space. Retromesenteric space is a little subspace. It is a very potential space in the anterior layer of Gerota's fascia, and I'm sorry, it is in the posterior aspect of the anterior perineal space, and you do not see that usually. You do not see that with lymphadenopathy. This is basically lymphadenopathy that you're seeing here, and this is in the great vessel space. Great vessel space has recently been defined in the last 4 or 5 years. It lies between the two perinephric spaces, and it is part of the, it is ill-defined, and it is part of the retroperitoneum. It contains aorta, IVC, and the related lymph nodes. So because this is again an example of finding using all the information that is available to find out. So this is lymphadenopathy, and I think there's a question further on. This is lymphadenopathy, and retroperitoneal lymphadenopathy, if it is going behind the vessels, is going to be in the great vessel space. Which of the following explains the difference of appearance between the two kidneys? You should have all gotten it correct. It is very basic physiology, and what it is showing is that on the right side the kidney is in the nephrographic phase, whereas on the left side the kidney is in the corticomedullary phase. So which one is abnormal? It is the left one. Both kidneys should be in the same phase, so the left kidney is lagging behind, and that is called a delayed nephrogram or delayed passage of contrast through the kidney. It is a delayed nephrographic phase. It is not a persistent nephrogram. Persistent nephrogram would be when later on, in much delayed images, where the other kidney has lost its nephrogram and the abnormal side has a persistent nephrogram. It is not poor concentrating ability. All you are seeing is the delayed nephrogram. Poor perfusion can be there, but not in this case, because in this case what you're seeing is that there is a dilated collecting system, and that is what is causing the delayed nephrogram. It is not because of poor perfusion. So the correct answer on this is delayed nephrogram. Another thing I want to draw your attention to is, please do not mistake this appearance for acute pyelonephritis. The acute pyelonephritis defects, they involve the cortex and the medulla and the cortex, whereas this one here, all you're seeing is that the cortex is bright and the medulla is dark. It is almost physiological, although it is not normal because it is delayed. Which of the following findings in this case suggests that the retroperitoneal mass is not a plaque of RPF? Those of you who could not get what RPF was, my apologies for using a abbreviation. Ruth, if you will please note that, and we will make a change. But if you did get RPF, this is not RPF. This is not retroperitoneal fibrosis, because what it is doing is it is extending behind the aorta. And in the classical descriptions, the RPF, the differentiation between RPF and retroperitoneal lymphadenopathy is that RPF lies in front, whereas retroperitoneal lymphadenopathy can extend behind the aorta. Enhancement can occur in both. Ureteric obstruction can occur in both. RPF can be unilateral or predominantly unilateral, and calcification does not matter at all. Which of the following is the most likely diagnosis? So here now what you have gotten is a lobulated mass in the retroperitoneum in the great vessel space. So the chances are that this is most likely that this is lymphadenopathy. It is extending behind the aorta, it is lobulated, and it is lying in the correct place. Now, lymphadenopathy, the most common cause of lymphadenopathy that you will find is lymphoma. But apart from that, you can get metastases and the other things, Whipple's disease and atypical mycobacteriosis and stuff like that. Lymphoma is usually bilateral. It can be unilateral, but it's usually bilateral. And if you find that there is lymphadenopathy predominantly at the level of the renal hilum, as here, and it is causing obstruction. Lymphoma, remember, does not cause obstruction of the collecting system. So if it is here, then it is most likely, because it's causing obstruction, it is most likely metastatic. And if because of its location, it is very characteristic of testicular cancer metastases in men. And the fact that we are giving you that choice means that this patient has to be a male. It would be foolish to give that choice in a female patient. So this is one of the things that was very has been a very big favorite of all GU radiologists, and the reason for that is that you will see, even in a general practice, you will see one such case every, I would say, 2 years. Mark my words, you will come across such a case where there is just lymphadenopathy, and it is, nobody knows what it is due to. The patient has some obstruction, so the patient presents with ureteric colic type images, and you can even see it on stone protocol CT. And you, as the radiologist, then have the responsibility to find that and then say, this could be due to testicular cancer metastases, and we need to do a testicular ultrasound. So keep that in mind. This kind of case will show up once in a while in your practice and much more commonly in your exams. Which of the following is the next best step? Once this question is really based on the previous one, once you have decided that this is a testicular, that this is likely to be metastatic disease from testicular cancer, then scrotal ultrasound is the way to go. So if you don't learn anything from this case, learn this. Lymphadenopathy at the level of the renal hilum, consider testicular metastases first. Okay, so where is this abnormality arising from? You have to know where the abnormalities arise from. Sometimes, like I said, you have to use all the information that is available on the image. So could it be from the mesentery? Well, the mesentery is lying here. So this is not from the mesentery. Could it be from the omentum? Yes, it could be. But then the entire left retroperitoneum is enlarged too. So there is unlikely, there is no likely condition that would cause omental origin and retroperitoneal origin of a fatty mass. Is it arising from the kidney? Just on this image, we do not see a notch, renal notch, or the claw sign for it to be arising from the kidney. Is it arising from the psoas muscle? It is invading the psoas muscle, yes, but then there is a whole lot of this fatty component which is not going to be arising from the psoas muscle. By now you know what the diagnosis is, and I hope that anyway, so this CT scan was obtained at 140 kVp. Which of the following effects will be seen on the image if kVp were reduced to 80 while keeping the tube current the same? Decreasing the kVp to 80 will actually increase the noise throughout the image. It will not cause decreased brightness of the blood vessels because it will, the iodine containing blood vessels will appear brighter. It will not cause increased radiation dose, and because of the presence of noise, your SNR will go down and the spatial resolution will also go down. As far as the better detection of liver lesions, one could say, well, because it is an enhanced liver, it would cause better conspicuity of the liver lesions. But remember, liver lesions in a liver are low contrast situations, and therefore they are affected much more by the increased noise, and therefore they are not going to be, their detectability is not going to be better. So it is the increased noise throughout the image that will be caused by that. Which of the following is the most likely diagnosis? And again, I am a little surprised, but that's okay. This is the time to learn. This is a retroperitoneal liposarcoma. It is not a lipoma. It is a fat-containing tumor. It also has some soft tissue components. This is called a dedifferentiated retroperitoneal liposarcoma. Even if that soft tissue component were not there, you would still not call it a retroperitoneal lipoma. Remember that it is one of those things which can rarely occur somewhere, like a retroperitoneal lipoma is one of those things which can rarely occur somewhere, but you will never make a prospective diagnosis, because if you do, 9,999 times out of 10,000 you will be wrong. Same thing with renal oncocytomas, but that's a different matter. So never call a retroperitoneal fatty tumor as a lipoma. Always a liposarcoma. Is this a psoas hemorrhage? Well, if it was just this one present, we could say, but once you identify the fatty element, no, it's not. Similarly, not a psoas abscess, fatty element goes against it. Could it be a retroperitoneal rhabdomyosarcomas? Very rare. Rhabdomyosarcomas mostly occur in the urinary bladder, in the vagina, and in the head and neck, in the nasopharynx, in children. So this is a retroperitoneal liposarcoma. They all look bizarre. Now, whenever you have a bizarre appearance of the retroperitoneum, of the image, there's something going on, very involved. Consider retroperitoneal liposarcoma. And the second thing that can give rise to a bizarre appearance but not fat is a plexiform neurofibroma. Which of the following tumor features in this case favor a liposarcoma over a giant angiomyolipoma? Now, very big angiomyolipomas can have somewhat similar, not exactly, but somewhat similar. You could say, well, there is fat, maybe I'll find a notch. Well, one is, if you don't find a notch, it is unlikely to be a giant angiomyolipoma. But that is not one of your choices. Giant angiomyolipomas almost always have large vessels running through the tumor, whereas the liposarcoma does not. They have these thin septations running through it, and that's okay, but there are no large vessels that you can see coursing through this, and that is the feature in this case that favors a liposarcoma and rather than a giant angiomyolipoma. Calcifications do not matter. Angiomyolipomas do not calcify, but liposarcomas may or may not calcify. Presence of soft tissue component, you'll have fat and soft tissue in a angiomyolipoma as well as in a liposarcoma. Displacement of the kidney, depending on how big the tumor is, kidney can be displaced by either of those, but no large vessels in liposarcoma. In performing an image-guided biopsy of the tumor shown, which is in a liposarcoma, which of the following areas should be targeted? It is all radiologically distinct areas. You will biopsy this, you will biopsy this, you'll biopsy this, you'll biopsy this. Because this tumor has a good prognosis, the treatment is with debulking, and therefore the surgeon needs to know how far that debulking is going on, how far to go with that debulking. And also later on when the tumor recurs, you want to know, is it recurring in a site of where previously a tumor was there or not. Case 5, which of the following should be the next step in this IVU to show the abnormality better? So what you have is just a full bladder image. That is the ureter here, the ureter here. So what do you need to do? Of course, you will look at all the other images, but you need a post-void image. Very important. Post-void, whenever you're looking at the urinary bladder, you need to look at the post-void image before giving your diagnosis. It's a known fact for people who practice IVP, and by the way, don't make any mistakes. You will be practicing IVP as you go into practice, unless you're in a very specialized practice. You will do at least 2 to 5 IVPs a day. So you need to be able to identify, to be able to read an IVP. So you're not going to obtain image with compression. That doesn't work in the urinary bladder. That is only to see the collecting systems, and then in post-release the ureters. You are not going to obtain a prone image. That's not going to help you. You're not going to obtain a delayed image, and you have not yet finished the exam, so please do not terminate the exam. What you need to do is a post-void image. So now in the post-void image, which of the following inferences can be drawn? So in this, what you're seeing is that there is a, excuse me for one moment, please. Give
Dr. Chopra asked for just one moment, and he'll be right back.
All right, I'm back. I did let you know. Maybe you, people got a little mesmerized, but that's okay. Okay, so question number 2. Which of the following inferences can be deduced from the findings? And what you're seeing here is that this is the full bladder image, and this is the post-void image. Did you all see this mass? That is the finding. Yeah, there's a prostatic impression at the base, but this irregular mass is the finding. So what has happened is that in the pre-void image or in the full bladder image, this was not seen very well. You can make it out, but still you can't see it much. But in the post-void image, it becomes very clear because it was being obscured by contrast. That phenomenon is very typical of the presence of an intrinsic mass in the urinary bladder. An extrinsic mass would be much more prominent in the full bladder images, and as the bladder empties, it falls away from the intrinsic mass, and therefore would fall away from an extrinsic mass, and therefore it would become less prominent. So there is not significant bladder outlet obstruction. There's very little post-void residual. This is not an extrinsic impression. It becomes more prominent. It is an intrinsic mass. And of course, this post-void image is showing a lot of information. Which of the following is the most likely diagnosis? It is a bladder cancer. Unlikely to be a blood clot. It is too irregular. It is attached to one place. It does not change position. Sloughed papilla should not be that big. Fungal ball, again, attached. Fungal ball looks bizarre, and it's in the center of the urinary bladder. So bladder cancer is the answer in this case. Here is the mass for those of you who could not see it. See that filling defect? If you look at the bladder, it's as if somebody has taken a bite out of that corner. Based on the full bladder image, which of the following is likely to be the most appropriate treatment? And that is depending on, okay, so to deal with this question, you need to know what are the ways of treating the urinary bladder. Laser fulguration was used in the past, not anymore. It was used for papillary cancers. TURBT is the transurethral resection of the bladder tumor, which is done in almost all cases. And then from that TURBT, people look at whether there is any invasion of the urinary bladder wall muscle or not. The most important thing is this a muscle invasive tumor or not? If it is a muscle invasive tumor, the patient needs radical cystectomy. So in this case, is there anything that tells us that this is most likely a muscle invasive tumor? Of course. If you look at the retraction of the urinary bladder wall over here, that is a radiologic sign of muscle invasion. It is seen well on CT, it is seen well on IVT, or anywhere where you're trying to, where the bladder is distended, but this part of the wall cannot expand because it has been invaded by this tumor. So the treatment in this case would most likely, the most appropriate treatment would be radical cystectomy. Of course, the patient will go through TUR, BT, and everything, but will end up getting a radical cystectomy. Okay, case. Oh, that one was on this particular image, that last question, but that's fine. Case 6, so in which part of the kidney is the abnormality located? It is in the medulla. Why do we say that? Because these are the abnormal areas, and they are located, they should not be bright. How do we know these are pyramids? One is that they are triangular. Number two, they are arranged in a radial fashion around the center of the kidney. So this is, columns of Bertin are between them. The cortex is right here. The cortex appears thinned in this case because normally you're used to seeing the cortex and the medulla together, and it forms that much thickness. But here it is really the medulla that is abnormal. And which of the following findings is present in this case? It is the hyperechogenicity of the pyramids, and there is some shadowing too from those pyramids. We didn't give it to you as a choice, but it is there. And now the question arises, if you wanted to intensify the acoustic shadowing, what would you do? And the answer to that is you would use a higher frequency transducer. Anytime you use, want to increase the shadowing, you want to use a high frequency transducer. Why? Because the higher the frequency of the sound waves, the more attenuation it occurs and their penetration decreases. So no need for power imaging, that is color for flow. Increasing the TGC is not going to do anything. Increasing the overall power will just make the image brighter. Using a higher frequency transducer is important. Considering that half of you did not get this question, I would suggest to all of you to actually go to your ultrasound department and play with the controls a little bit. That will give you a much better idea as to what to do, how to deal with different situations that arise in ultrasound. The most likely diagnosis in this case, once you have identified the hyperechoic pyramids with shadowing, is medullary nephrocalcinosis. The others are not correct diagnosis. And the most common cause of medullary nephrocalcinosis is primary hyperparathyroidism. And this is, again, this is a basic internal medicine question, but again, because we deal with this stuff, we need to know it. Secondary hyperparathyroidism occurs in patients who have renal failure, and they do not have hypercalcemia. They have hypocalcemia, and therefore their parathyroids are secreting more. Tertiary hyperparathyroidism, again, occurs in a patient with secondary hyperparathyroidism, where the parathyroids have become autonomous. And pseudohypoparathyroidism has nothing to do with blood serum calcium levels. That is the lack of sensitivity of the tissues to parathyroid hormones. So the correct answer, all of you should know it, is primary hyperparathyroidism. Which are the other two causes? Major: renal tubular acidosis and medullary sponge kidney. So primary hyperparathyroidism most common, medullary sponge kidney, and renal tubular acidosis. Somebody could also ask you which organ would you look at in this patient, and it would be the parathyroid. How would you look at it? technetium, the maybe scan, or one of the subtraction scans. So different ways to ask that same question. Where is the abnormality located in this case? What you're finding is that there is an abnormality around the left kidney. And I should have said, where is the renal abnormality located? Ruth, if you will please make that distinction, because there are other abnormalities present too. There's an IVC filter here. In the left kidney, there is this material around the kidney, which could be in the perinephric space or subcapsular space. This is the Gerota's fascia here. And posteriorly, it is kind of compressed backwards, and the posterior pararenal space is a potential space anyway. So this thing is in the, it is not outside of the Gerota's fascia. That is number one. Number two, look at how it is compressing the kidney. That means that this area is under a lot of pressure. That occurs in patients with subcapsular space abnormality rather than in the perinephric or pararenal abnormality. There is no history of trauma or instrumentations. How valuable is it to obtain an excretory phase CT urogram series next? And the answer to that is you don't expect any helpful information, because you would do an excretory phase if you were suspecting that there is a urinoma. There's obviously no obstruction, but urinoma you would suspect if there is trauma or instrumentation. In the absence of that, looking at the excretory phase is not going to help you. All it will show is the collecting systems that are opacified. So the answer is no helpful information. Which of the following is the most likely diagnosis? Now here, again, once you have made up your mind that this is a subcapsular hematoma, again think, you do not need a excretory phase. It is not pyelonephritis because the renal parenchyma is very well and uniformly enhanced. This is not a renal cell carcinoma. They don't occur like that. The only thing you could consider is a renal lymphoma, which does involve the perinephric space, or has a perinephric or subcapsular extension. But you expect there to be some lymphadenopathy, and also for it to be involving the renal sinus. So just isolated perinephric involvement is less likely in renal lymphoma as compared to subcapsular hematoma. So it's a high-density material in it. Actually, this patient had a surgery, developed a DVT, for which they were started on heparin, developed this hematoma, and then an IVC filter was placed. What would you do next in this case? Is steadily improving. Which of the following steps is appropriate in the management of this condition? And really, you don't need to do a percutaneous biopsy. The patient is improving. You don't need to do a percutaneous drainage, because you do not want to touch a renal, any hematoma anywhere in the body unless it is very symptomatic or you're thinking infection, because you are going to infect it. You don't need to do renal angiography because you're not looking for an acute bleed. The patient is improving. But you do want to know whether there is follow-up, whether there is a renal mass that may be obscured by this hematoma or not. Because although spontaneous hematomas, let me put it this way, whenever you see a spontaneous hematoma without history of trauma or instrumentation, two things that should come to your mind is, number one is this patient, do they have coagulopathy? And or the other thing is, do they have a renal mass? So yes, renal mass protocol is the same thing as the CT, the triple phase CT, and this is the correct answer. This is what you need to do. Now, some of you may have written surgical decortication because whenever we look at a subcapsular hematoma, we start thinking, oh, is this going to become a Page kidney? Is this going to become a Page kidney? Page kidney phenomenon is extremely rare. It is the development of hypertension in a patient who has a chronic subcapsular hematoma. It is extremely rare, number one, and number two, even if it does occur, it is treated with medical treatment. You do not need a surgical decortication. Case 8. This is a diagnosis that if you've seen it once, you have seen them all. This is a urethral diverticulum. And it is around the urethra. Whenever you're looking at the pelvis, identify the 3 viscera that go through the pelvis. This is the urinary tract, the genital tract, and the GI tract, rectum. So there is this collection around the urethra. It is very anterior. This is a typical urethral diverticulum. It is not a Foley balloon because the Foley balloon has the central tube going through it which contains air. This is not a vaginal cyst. Vaginal cysts occur on the side of the vagina, not anteriorly like that, and it is even anterior to the urethra. It is not an ectopic pregnancy. That's nonsense. Cystocele would be, again, it has a very different look, and it involves the entire anterior portion, anterior to the vagina, rather than a localized diverticulum or localized collection like this. So this is a typical urethral diverticulum. From which wall of the urethra does a urethral diverticulum arise? Just looking at it, you could say, well, it seems to be surrounding the entire urethra. But what has happened is urethral diverticulum always arises from the posterolateral wall of the urethra here. So it's arising from here, and then as it begins to grow, it has nowhere to go except wrap around the urethra, because there is a very strong perineal body, a very fibrous perineal body lying there, which takes the weight of the entire pelvic viscera in the upright position. So that's not going to let this diverticulum grow in any direction. So it begins to wrap around the urethra. It arises from the posterolateral wall because the paraurethral glands are located in 2 rows along the posterolateral walls of the urethra. Which of the following is the preferred test in a patient with suspected urethral diverticulum? Here we know already there is a urethral diverticulum, but if the patient comes to you and the clinician is suspecting a urethral diverticulum, you will do an MR of the pelvis. The money shot in MR of the pelvis is T2 weighted images in the coronal plane. They will show you the urethral diverticulum. Voiding cystourethrogram is not going to help because a lot of times it will not fill with the contrast. Transvaginal sonogram is of no use. Retrograde urethrogram, again, does not fill. There used to be a double balloon urethrogram where you inflated 2 balloons, one in the urinary bladder and the other outside, to seal the urethra to increase the pressure enough. But that also is not done nowadays because MR pelvis has a very high sensitivity for this. Which of the following is the preferred sequence of a diagnosis for the diagnosis? And like I said, it is T2 with fat saturation, because what you're looking for is the fluid collection. Case 9, which of the following is responsible for the curved radiolucent band in the urinary bladder? This is called the interureteric ridge. What it means is that it actually runs between the 2 UVJs, and what it means is that even if here we are seeing the right kidney, but even if, let's say, you didn't see the right or the left kidney, if you have a complete interureteric ridge, that means that a kidney did develop at some point, and if we are not seeing it, it's not due to congenital absence. When you don't, when there is congenital absence of the kidney or the ureter on that side, you won't see the interureteric ridge going on to that side. Which of the following measures is not appropriate to improve visualization of the ureters during an IVP? Now, what is not appropriate is imaging after IV furosemide. And those of you who thought that imaging after IV furosemide was appropriate, please do remember we are talking IVP, not CT urogram. When you do a CT urogram, the major problem there is not whether you will be able to see the contrast in the ureters or not, because CT has such good contrast resolution. The major problem in those cases is, are you going to be able to distend the ureters enough to catch them in that one instance of the CT when you're doing the CT? And therefore you always give some kind of diuresis. We use just oral water, but IV fluids have been used and IV furosemide has been used. But if you give IV furosemide in an IVP, all it is going to do is wash out the contrast, make it so dilute that you will not be able to, that it will not improve the visualization of the ureters, it will even take them away. Now, you can do an imaging in prone position because the ureters are located more anterior to the collecting systems. When you put the patient prone, the contrast goes pretty quickly into the ureters and you'll be able to see them. You can do imaging after additional IV contrast because that will give you more concentration of contrast and you'll be able to see the ureters. And you can do an image after compression release. You probably have not seen compression release, but all of your departments do have that. Go to fluoro and ask them, what is this compression during IVP? These are two air balloons that you put in the suprapubic region, actually a little higher. And when you compress it, and there's a belt you put around that, and when you inflate them, it stops the flow of urine going down from the ureters. So what it does is it actually fills up the collecting system first during the compression, and when you release it, all that contrast then has to go down, and that is called a compression release, and it improves your ureteric visualization. Which of the following is the most significant abnormality present in this case? And here what we have is the presence of filling defects in the opacified structures. There's one here, and then there's the other one over here. There's the collecting system is not distorted. This one is a little spastic, but so what? That's okay. There must be a parapelvic cyst or something that is spidery. There is no dilatation. All you have really is filling defects in the opacified structures. Which of the following is the most likely diagnosis once you have found that there is a filling defect here and here? This is a renal and ureteric TCC. Why not renal and ureteric stones and renal and ureteric blood clots? If you actually look at this, this is an irregular polypoid mass, so this is most likely a TCC. And this one over here, let me see if I can increase the, this one over here is giving you a champagne glass deformity, where this is the stem and that is the goblet of the champagne glass. That is very typical of a ureteric neoplasm. If there were a stone, the ureter would be in spasm around that rather than dilated like this. Okay. Which of the following is the next best step? CT urogram is not going to give you any more information because we have already gotten it. Ureteroscopy is the thing to do for identifying the those tumors and getting the biopsies. MR with Magnavist is not going to help. PET CT is not going to help. CT abdomen and pelvis with contrast will be needed at some point when you start staging that cancer, but not at this point because the diagnosis is pretty clear to you, and all you need to do is to confirm it. Okay, which of the following is the most common congenital anomaly of the renal veins? It is, there's no right renal vein is never retroaortic. The right renal vein is never circumaortic. So these two are out. Then the question arises out of these two. Circumaortic renal vein is found in about 10 to 15% of cases. Retroaortic renal vein occurs in 2 to 3% of cases. And actually, whenever you see a retroaortic vein, if you look hard enough, you will find a circumaortic vein. In the retroaortic vein, the anterior vein that goes anterior to the aorta receives the gonadal vein. The vein that goes posterior to the aorta receives the adrenal vein. And that is sometimes useful in knowing when you're doing the adrenal vein sampling and stuff like that. But it is the circumaortic left renal vein that is the commonest congenital anomaly of the renal veins. You will see it very commonly. Now, of course, it's not present in this. This was just an unrelated question unrelated to the image. Now, does this patient need CT renal mass protocol? Again, CT renal mass protocol is the same as a three-phase CT or a triple-phase CT. And the question is, does this patient need that or not? Well, this one is a cyst. So not for this lesion, but the question was for the left renal lesion. This one has fat in it without any calcification. So even if you did a three-phase study, you're not going to get any extra information from that. All you will still, after that, you'll say, well, there is a fatty tumor, and that's it. And that is, fatty tumors are mostly angiomyolipomas. If there is calcification in a fatty tumor, then it is unlikely to be an angiomyolipoma, because then the angiomyolipomas do not calcify. So which of the following is the most likely diagnosis for this left renal? It is not a fatty renal cancer, because almost invariably renal cancers that have fat in them, that have macroscopic fat in them, have calcification. It is not a liposarcoma. It is arising from the kidney. It is not a myelolipoma. It is arising from the kidney. So the answer is this is an angiomyolipoma. And then the next question arises, which of the following findings is the most against the left renal lesion being a fat-containing RCC? Presence of fat, of course, we are talking about a fat-containing RCC, so that doesn't mean anything. Presence of blood vessels, it's an angiomyolipoma. So there is going to be blood vessels in there. And the renal tumors are also going to contain blood vessels. Renal claw sign, both of them will show because they're arising from the kidneys. It is the lack of calcium that goes in favor of a angiomyolipoma rather than an RCC. Which of the following is the indication of treatment of left renal angiomyolipoma in this patient? All these are indications for treatment, but in this case the size is not more than 4 centimeters, so that is unlikely. There is no hemorrhage from this lesion that we are seeing, so that is not true. The diagnosis is pretty clear, so again, we don't need to do anything for that. It is this aneurysmal blood vessel that is running through. So if there is an aneurysmal blood vessel that measures more than 5 millimeters in diameter that runs through the angiomyolipoma, it is at a much higher risk for bleeding than those without an aneurysmal blood vessel. Okay, in which of the following locations is the renal calcification predominantly located in this patient? It is in the cortex. It is not in the collecting system, and it is not located in the medulla. That would be on the inside and radially located. These are lobules, the cortical lobules that are calcified. And actually, if you see, there are some central lucent areas which are really the medulla that is not calcified. Which of the following is the most likely diagnosis? Once you have seen this picture, this is actually a renal cortical necrosis, but unilateral renal cortical necrosis like this occurs only in renal tuberculosis. So this is a putty kidney. Renal cortical necrosis looks very similar to this, but is bilateral, because that was, and we hardly ever see it nowadays, because it was seen when the therapy for shock was not well formed, and people after postpartum hemorrhage or hemorrhage during trauma would develop bilateral renal necrosis. Dead transplants do not, they look like this, but they do not occur in this area. They're always down in the pelvis. Calcified tumor is unlikely to maintain a reniform shape, and this is not medullary nephrocalcinosis, because medullary nephrocalcinosis is never bright enough to be seen like that on plain films, and it is not in the location of the medulla. Which of the following findings is expected on the IVP in this patient? You won't see a delayed nephrogram, you won't see dilated calyces, multiple strictures in the left ureter. You would see if the ureter was opacified, but that ureter is not going to opacify because there is no function left in this kidney. Putty kidney is also called autonephrectomy. It is very typical of renal tuberculosis. Which of the following is the most likely aim of further imaging in this patient? It is not the assessment, it is the left renal function is already gone. There is no obstruction. This is just calcification of the entire kidney. It is the assessment of the condition of the right kidney. You want to know how the right kidney is doing, and IVP is a good enough way of doing it, but that would be your aim of doing any kind of further imaging. Vascularity of this lesion, that doesn't mean evaluation for neoplasm. That's not true either. Which of the following is the most appropriate step in the interpretation of the image provided? If you have not been shown a SCOUT and there is contrast in the kidneys, the first thing to do is to look at the SCOUT image. When we used to prepare people for oral contrast, for the oral exams, we used to tell them, shout for SCOUT. They had to ask for SCOUT. And that requirement is not going to disappear just because now the questions are being asked in a multiple choice question fashion. You will come across those kind of questions as to whether you're going to ask for SCOUT or not. So in this, what you're seeing is the left kidney is normal actually. The right side is very distorted. And there are these bright areas. You do not know whether these are stones or are these actually collections of contrast. Now, which of the following description applies to the abnormality of the renal axis in this image? Here, there is the lateral displacement of the right renal pole. This kidney has a normal obliquity. This one is too oblique. The right renal pole is far away. Why? Because there is most likely a mass here that is pushing the lower pole of the right kidney. Now, the SCOUT images did not show stones. Which of the following is most appropriate for the abnormality on the right? How do you describe it? And the finding in this case is that there is collecting system distortion. It is not just dilatation. This system actually is not dilated. It is compressed by the tumor in an AP dimension and is therefore being distorted, but it looks as if it's rounded and it's dilated. How do we know that it is not dilated? Because if you look at this, if this was dilated, it would be much more bright to contain that much of contrast within it. So a large collecting system with very little contrast, with less contrast, that means it is being compressed, not dilated. This is not a delayed nephrogram or a persistent nephrogram. We have not reached that point yet. Now, although it was rated as 2.75, remember all the ratings that came from the previous batch of people who took this, they are rating it based on their experience of an N of 1. So we do believe that this is an important question. At some point or another, something may show up that may look similar, not the same. Considering that the SCOUT did not show stone, which of the following is the correct inference drawn from the abnormality shown? So whenever there is a distortion of the collecting system, you have to consider a renal mass. It's not a right UPJ obstruction. It's not behaving like that. There is no scarring. The outline is very nicely seen. There is no rupture here. You don't see anything in the perinephric or in the renal sinus. And this is not XGP. XGP does not look like that. XGP really has absence of function. So this is actually a mass. And the mass in this case was here. And that is the compressed collecting system that you were seeing. And see, because it is expanded from side to side, it looks big on IVP, but it's actually compressed. Then the question arises, which one is it? Renal cell carcinoma, renal abscess, renal lymphoma? First thing is that this is, even though there is necrosis in the center, there is no abnormal enhancement. So renal abscess is almost out because of that. Medullary type renal carcinoma, transitional cell carcinoma, and renal lymphomas, all of them can cause an infiltrative type, because this is an infiltrative type mass where it is arising from somewhere from the center and is extending into the renal parenchyma from inside. It's not arising from the renal parenchyma itself. And out of all these three, transitional cell carcinoma is the most common cause of an infiltrative type renal mass. So it is a TCC of the collecting system, right pelvis, which has then invaded into the renal parenchyma. Now, which of the following other IVP images would you like to view before commenting on the abnormality in this case? Same type of question as we asked before, but again to bring out the importance. Scout image. Because the abnormality is located here, what you need to know is, are these stones or are these collections of IV contrast? And which of the following is the anatomic location? They are in the papillae of the pyramid. What is the difference between papilla and the pyramid? Papilla is that part of the pyramid that is surrounded by the calyceal cup. Beyond that, the pyramid you don't see. It will go up like that, but the portion that opens into the calyceal cup is the papilla, or the nipple as you would call it if you looked at it from inside. The Scout view did not show any calcifications. Which of the following is the most likely diagnosis? And of course here, once you start seeing extracalyceal contrast, whether it is flame-shaped, ball on T phenomenon, this is papillary necrosis. All of you almost got it. And which of the following is the next best step in this management? You want to assess the renal function. You want to know how is this patient functioning. One would have hoped that renal function was looked at before, but if it's a young patient, you may not have done creatinine before. But once you have seen that, you need to do renal function. Renal ultrasound is not going to tell you anything. CT urogram, MR urogram will show you the diagnosis, will show you the findings, but they will not make you any wiser about what's going on. Which of the following drugs is most likely to be associated with this condition? Non-steroidal anti-inflammatory agents are the most common. And most commonly, it is found in patients with diabetes, and they're found in most commonly in patients with diabetes, and it is said that any patient with diabetes who develops sudden deterioration of renal function, you should suspect papillary necrosis. So in modern practice, we will hardly, I don't think you will ever come across this, except that sometimes some chronic papillary necrosis patients may show up. Which of the, next is, which of the following is the correct name for this examination? It is a retrograde cystogram. It is not a voiding cystourethrogram. We are not going to remove the catheter and let the patient void. It is not an IVP. These are not ureters. It is a retrograde. It's a retrograde cystourethrogram, or even just cystogram. It's not just a retrograde urethrogram because the catheter is lying in the urinary bladder. For a retrograde urethrogram, you would leave it in the fossa navicularis of the penis, and then inject contrast. In which of the following structures is a contrast adjacent to the urinary bladder located? Here, it is in the extraperitoneal space. It's not in the distal ureters. It is just too flame-shaped. It is not in a tube. These are not Hutch diverticula. Again, diverticula would be much better defined and will have much more contrast. And it's not in the peritoneal cavity because we have already shown you intraperitoneal contrast. So which of the following is not present in these images? There is a pelvic fracture here. The bladder is pear-shaped, and there is contrast outside of the bladder. What you're not seeing is outlining of the bowel loops. Why? Because this is an extraperitoneal rupture, bladder rupture. And that is the correct diagnosis. It is not a type 2 urethral rupture that occurs down below here. There's no contrast here. There's no extravasation of contrast from that. What you're seeing is just the urinary bladder with a trauma. It is not ureteric injury, and it is not a forniceal rupture. That would be much higher, and contrast would be in the kidneys. So which of the following is the best approach? And I'm surprised here that we didn't get all of them correct because most of you got the diagnosis of extraperitoneal bladder rupture correct. So once you've got that correct, then you know that the treatment of extraperitoneal bladder rupture is through is by non-operative means. This is just to show you these images side by side. This is intraperitoneal. This is extraperitoneal. Intra, extra. How do we differentiate? In extraperitoneal, the urinary bladder is full and it is pear-shaped. Pear-shaped because of the hematoma. Full because where the contrast is extravasating into is a very high resistance potential space. Here the urinary bladder is flattened. It is almost empty because the contrast is very easy for the contrast to go into the peritoneal cavity. Here we are seeing these loops of small bowel. There we are not. Here the extravasated contrast is kind of irregular, flame-shaped. To me, this bladder looks as if like the Joan of Arc appearance, as if there is flames coming out from the feet of this bladder. And here, it is well defined by that peritoneal cavity, that well-defined line. Okay. Let's go now to case 15. Which of the following is the structure marked by the red asterisk? It is the crus of the diaphragm, right crus of the diaphragm. It is not an aortocaval lymph node. There is the diaphragm coming down and it is forming a crus. And this is not cisterna chyli. That appears lower at the level of L3 vertebra and it has a fluid appearance. This is not the right adrenal gland. Right adrenal would show up here. If to some of you it looked like the aortocaval lymph node, I don't blame you. It is, I think, Ruth, if you will note it down, we should probably change that, this particular choice, because that may be a little bit confusing, but otherwise I want you to know that something that looks like a lymph node in this region, think of could this be the right crus of the diaphragm? More than one people have been, and in practice, have been burnt by calling this a lymph node when it is not. Which of the following is responsible for increasing attenuation of medullary pyramids from corticomedullary to nephrographic phase? So this is the corticomedullary phase. And as you go later further on, these pyramids will become bright also, and they will be then it will become the nephrographic phase. They will be as bright as the cortex. And the question is, what is it that is making them bright? You may or may not have thought about it, what happens? Is there delayed blood supply to the pyramids? Shouldn't be. The contrast is going in. It should supply the whole organ. Is there a vasodilatation of the medullary vessels? Doesn't make sense. What happens is, and there is no increasing concentration of intravascular contrast. What happens is that in the corticomedullary phase, the cortex is bright and the medulla is dark because cortex is bright and medulla is dark because the medulla has less blood supply than the cortex. However, as we go from corticomedullary to the nephrographic phase, what is happening is there are all the glomeruli in here which have begun to now pour urine out, contrast into the urine, and it comes into the tubules and starts getting concentrated. So in those 90 seconds, it's as quick as that it takes. The contrast is within the urine in the pyramids, and the concentration has increased to the point where it is the same as the rest of the cortex. So that is why in the nephrographic phase you don't see the differentiation. Now if you go further on, delayed nephrographic, right before it begins to excrete, you'll find that these medullary pyramids are actually brighter than the cortex because of the concentration of urinary contrast. Which of the following in this case is most against reflux nephropathy? Collecting system dilatation may or may not be present in reflux nephropathy. Kidney will be small in size in reflux nephropathy. Reflux nephropathy can be unilateral or bilateral. But what reflux nephropathy doesn't do is a smooth renal outline or a smooth atrophy. So small kidney, unilateral small kidney can be smooth or scarred. If it is scarred, then reflux nephropathy. If it is smooth, then it can be due to renal artery stenosis or, due to a vascular cause or post-obstructive atrophy. Post-obstructive atrophy is that there was obstruction in the past, it was relieved, and the kidney kind of collapsed. The renal parenchyma was atrophied. And even though the obstruction has been relieved, you will still find some dilatation of the collecting system. The fact that in this small smooth kidney there is no dilatation of the collecting system goes in favor of that this is an ischemic rather than post-obstructive atrophy. And of course, once you go to this one, you know that there is a chronic aortic dissection, which when it was acute caught the renal artery on that side. Okay, doing very well, almost there. Case 16. Which of the following findings is present in this X-ray of the lumbar spine obtained for back pain? Of course, there is urinary tract opacification, should not be there. So once you see the urinary tract opacification, you want to know why, and the patient had a contrast-enhanced CT in the past. Now, to make any further, to come to any further conclusion, you need to know when was the contrast given, not anything else. When was the contrast given? And in this patient, this contrast was given 8 hours before, and still you have a nephrogram. That is called a persistent nephrogram, not delayed. We don't know whether it was delayed or not, but we know that this is a persistent nephrogram. Negative nephrogram occurs in hydronephrosis when you just see that instead of that there are big holes in the kidney. That is not the case here. So which of the following is the most likely diagnosis? It is contrast-induced nephropathy because the patient has persistent nephrogram, and actually which of the following is the usual pathology? It is acute tubular necrosis that causes contrast-induced nephropathy. None of these are correct. Acute tubular necrosis, so this is a typical case of contrast-induced nephropathy. And actually, yours truly, on 20th of August 2006, I was sitting in my, I think it was a Sunday, and I was going through a stack of images or a work list, and there it was. Patient had pain, back pain, is admitted in the hospital, has back pain, develops back pain. So they say, oh, let's do a lumbar X-ray lumbar spine. Why would a young patient suddenly develop back pain from a lumbar cause in a hospital bed? So then it depends on the radiologist to notice this and say, you know, there's something wrong with these kidneys. And at that point, then they did the assess the renal function by doing the serum creatinine, and there it is. There it is. The patient had contrast-induced nephropathy. So that is the end. I'll look at the questions now. We have ended the discussion. We are at the end of the discussion. So those of you who are running short on time and need to leave, that is fine. Otherwise, I'll go through them in the next 15 minutes, see what all we can do.
Dr. Chopra, can you please look at case 16, question 5?
Case 16, question 5. I did review case 16, question 5. That was the question when it said, what is the usual pathology responsible for contrast-induced nephropathy? And the answer is acute tubular necrosis. Okay. Let us see. And Ruth, thank you very much. You have flagged the questions that are academic. And okay, case 1, question 2. Where would the fluid be? Like I said before, it could be in the parenchyma, subcapsular, perinephric, but the important thing is whether the patient is forming pus or not. Why cannot this be pyonephrosis and abscess, as they can also form gas from microorganisms? Once they have formed gas, okay, two things. It's not a pyonephrosis because, and yeah, it's not pyonephrosis because the system is not dilated. Pyonephrosis means presence of pus in a dilated collecting system, which is already hydronephrotic. So there's no hydronephrosis. Abscess, now it could be an abscess, except that you see this diffuse air within the parenchyma, and an abscess does not do that. An abscess forms a circumscribed collection of fluid and may have some gas. But here the entire kidney has been infected and contains gas, so this is emphysematous pyelonephritis rather than abscess. Can you go over how to differentiate between extra and intra? We did that right at the end of the extra peritoneal rupture case. Case 2 is the study of VCUG. No, it is not. It is a retrograde cystogram. VCUG you will say only if you see voiding. Now you will do a retrograde cystogram before have the patient void. So, but if we show you a voiding, then it is VCUG, otherwise it's not. Molar tooth appearance, don't know what that is other than presence of a molar tooth in a, I mean, I don't know what that is other than the presence of a molar tooth in a dermoid cyst. Can you explain case 2, question 5? Why do you do a post-drainage image? Okay. Post-drainage image is done in all cystographic studies. Anytime you look at the bladder, you see it full, then you do a post-drainage. And the reason for that is because you do not know what else is being obscured by this contrast within the bladder. Is there any extra peritoneal rupture also? We don't know unless we do a post-void or post-drainage image. How do you know in case 3, question 4, whether the mass is retroperitoneal lymphadenopathy and not a sarcoma. The masses that arise from the there are actually two reasons. Masses that arise from the or in the great vessel space are much more likely to be retroperitoneal lymphadenopathy. That is number one. Number two, whenever you see a lobulation of a mass, that is again goes in favor of retroperitoneal lymphadenopathy. Number three, retroperitoneal lymphadenopathy will often lift up the aorta, and the others usually, retroperitoneal fibrosis doesn't. Case 3, question 4, am I correct in understanding that you are saying that lymphomatous lymph node conglomerates do not cause urethral obstruction, but testicular mets do cause urethral obstruction? This is a well-defined, well-known generalization. Lymphoma is a soft tumor. Therefore, it causes very little obstruction of the blood vessels that run through it or any tubes that run through it. Not that it cannot, but metastatic disease is usually a hard tumor, wherever it is from. It is hard to touch, and that will cause obstruction of any tube that is lying in its vicinity or passing through it. So often when there is obstruction seen, metastatic disease is considered first, and lymphoma comes a little lower on the differential diagnostic list. Case 2, somebody said, can you explain the phases of the renal scan? Case 2, can't be case 2. Okay, it's in case 3. And okay, very simple. When you do a triple phase CT, you do a first phase is non-contrast, which is basically like a stone protocol. You're looking for any calcifications or stones. Second phase is the corticomedullary phase, which is the equivalent of the late arterial phase. It is done at about 20 to 25 seconds. The contrast is the cortex is bright, medulla is dark. So that is corticomedullary phase. By the time the contrast, like I explained before, it filters into the medullary tubules and begins to concentrate. So at around 75 to 90 seconds, and actually a little later, it is in the nephrographic phase. Nephrographic phase is slightly later than the portal venous phase because they're not really exactly the same mechanism that is causing the portal venous phase and the nephrographic phase. Okay, then case 4. So somebody's saying that this thing anteriorly, is this the mass invading? Yes, this is this retroperitoneal fat and not colon. Absolutely true. And a distended colon is not going to displace the bowel onto one side like this. That is the part of the colon. And what has happened is that where is the posterior layer of the peritoneum on the left side? On the right side, it is somewhere around here, right? But on the left side, it is lying here. It is almost as if somebody has put their foot under a rug and just flipped it over. So that entire mass is flipping over this peritoneum, the posterior layer of the peritoneum, so that this now whole thing is the retroperitoneum. So case 4, 1 and 3, can you repeat? So 3 is it is whenever you see all fatty tumors within the retroperitoneum, unless they're arising from the kidney, they are retroperitoneal sarcomas, liposarcomas, not lipomas. Okay. Case 4. I think case 5. Okay, this one. By decreasing KVP, I thought we changed contrast, and noise is a function of MAS. Noise is a function of MAS as well as KVP. As you reduce the KVP, the model increases, and that causes noise. The main source of noise in CT is the quantum model, and that will decrease. That will increase whether you decrease the KVP or decrease the MAS. Yes. Okay. Case 5, question 2. Can you point out the mass again? And I think I did. It is right here, and little bitty thing seen here. Okay, then case 7, what is the difference between subcapsular and perinephric space? Okay, that is, the kidney has from inside renal sinus, renal parenchyma, which is made of the medullary pyramids and the cortex. Outside the cortex is the renal capsule. Outside the renal capsule is perinephric fat in the perinephric space, which extends up to the Gerota's fascia. So here it is, the capsule is distended because of the blood, and this is the perinephric space, that fat right inside the Gerota's fascia. Can you point out where the left kidney is being compressed? Yes, if you compare the outline of the kidney, it is almost concave in some areas, whereas the right kidney is nice and plump. Case 7, question 4, shouldn't you decompress the kidney by draining the subcapsular hematoma? No, you don't want to touch the subcapsular hematoma. If there is ischemia developing, which is very rare, if there is acute ischemia developing, sure, you can do that. Otherwise, general principle, hematomas, leave them alone. The body will deal with them. If there is too much of symptoms or functional compromise, yes, you can do it. But in this case, it is nicely perfused. There is no need to touch this at all. Case, okay. Case 8. How is a urethrocoel different on image? And different, well, urethrocoels are going to be in the urinary bladder at the UVJ, not in the around the urethra. Case 12, what does ask for scout mean? Does it mean non-contrast image? Yes, when you do an IVP, the non-contrast image is called a scout image. Pyramids are in the medulla, correct or not? Pyramids are the medulla. For those of you who are not sure about this, this is the renal parenchyma. The cortex is bright. Pyramids, which are triangular looking, are dark. That is the medulla. And these pyramids are separated from each other by these columns of Bertin, which are part of the cortex, which come down, dip downwards, and produce and divide the medulla into medullary pyramids. So pyramids are the medulla. Case 13, where we said look for the renal function, and that was the autonephrectomy, the putty kidney. How would you do that? Would you do a nuclear medicine scan, or one moment, was that the putty kidney? No. Case 13. Okay, that was the papillary necrosis. Would you, how would you assess renal function? Creatinine or do nuclear medicine scan? Okay, if you want to assess the global renal function, which we want to do in this case, you want to do the serum creatinine and blood urea and all that stuff. If you want to do the split renal function, then you will do a nuclear medicine scan where, is what one kidney functioning more? We want to take out the right kidney, but is it functioning more than the left? Is there enough function in the left kidney? Then for splitting the renal function, you would do a nuclear medicine scan. Okay, case 15. Why is the right crus elevated? That is how it is in this case. Case 15, question 4, please explain post-obstructive atrophy. Let me see. Post-obstructive atrophy is that a patient develops chronic hydronephrosis due to whatever cause. It doesn't have to be very chronic. Basically, the collecting system dilates. When that happens, what happens to the renal parenchyma? It begins to atrophy. The kidney still looks big because there is hydronephrosis. Now, once you remove the obstruction, now we are in the post-obstructive phase, the hydronephrosis kind of goes away, and the renal parenchyma that is atrophic, that just collapses on itself, and it becomes a small, smooth kidney. How do we differentiate between that small, smooth kidney and the one produced from renal artery stenosis? By looking for renal collecting system dilatation. If it is dilated, it is post-obstructive atrophy. If it is not, then it is more likely to be a renal ischemia that is causing that. Whenever a kidney, can you explain smooth contour again? Whenever a kidney is small, a small kidney, or unilateral small kidney, then think of, is it smooth, or is it smooth, or is it scarred? And you have to be able to assess. You have to be able to assess the outline of the kidney and know whether it is smooth or scarred. If it is smooth, then, like I told you, ischemia or post-obstructive atrophy. If it is scarred, then it is due to reflux nephropathy, or very rarely a scarred kidney can be from multiple infarcts, for example, in a patient with sickle cell disease. Okay. Can you discuss or suggest a reference in the evaluation of a patient with urinary diversion? Do you do IVP or retrograde study through the stoma? If you do a retrograde study, do you normally see reflux into the ureters? Actually, yes. It is a very simple question. You are the second person who has asked this, so obviously there's some importance to this particular topic. To assess the, it is not the stoma, to assess the urinary system after urinary diversion, what should you do, IVP or a retrograde study? And the answer to that is you do a lupogram, that is a retrograde study. The reason you do a lupogram is because you are going to be able to see reflux on both sides. Because there is no reflux, anti-reflux mechanism left when you create a stoma. The bladder is gone, and there is no anti-reflux mechanism. So you are going to see reflux up into the into the ureters and collecting system, and if there is any recurrence in those areas, you will be able to see it much better. So then, and also the collecting systems may look slightly dilated because of that reflux, and that is a normal appearance of a post-diversion urinary tract. Then how do we know whether a ureter is obstructed or not? That you find out in the, again, post-drainage images. You drain it, let the patient walk around, and see if there is contrast hanging out still on one side. And so, and in that case, you will find, if there is obstruction to the ureter, then the contrast will stay there rather than drain out as on the opposite side. So that is how you differentiate between that is how you differentiate between non-obstructed and obstructed ureters of a post-diversion patient. How long do we wait for the pylographic phase? Okay, so the third phase in the renal study, that's the fourth phase, is the excretory phase, and that you can obtain anywhere between 3 to 10 minutes. Normally, to reduce the radiation dose, you combine the nephrographic and the pylographic phases together by doing a split bolus. And you give the contrast, let it excrete. After about 7 minutes, you give the remaining half of the contrast and do the scan. So if you're doing a split function study, it's around 7, not split function, but a split bolus CT urogram, it's done at about 7 minutes. But there is no hard and fast rule for pylographic phase. It can be done at any time. All right. So we are done with our discussion. Thank you very much for coming. Ruth, all yours.
Dr. Thank you so much, and thank you for your informative discussion. I'd like to remind all our enrollees that Dr. Attali will be presenting today at 2 o'clock, and it will be cardiac.
No, I'm sorry. I'm sorry. There is a change in that. I should have told you, Ruth. It is neuro today, and those of you, I think other than a few people, all of you did sign up for neuro tonight, and Dr. Attali will be doing it tomorrow evening.
Thank you. Thank you for correcting me.
All right.
Okay. And for